Okay, welcome everyone. We are excited to have you here today for our webinar on expanding your maternal and child health programs with the support of community health workers. Our partners at Linn County have been very gracious and offered to provide this webinar. We are very excited to share all this information with you. Before we get into the content, I just want to go over a couple of things. First, the agenda for today is that we're going to do housekeeping and some introductions, just really quick. We'll have about a half an hour for the full presentation, and then the last 15 minutes will be Q&A. I tried to get the chat set up so that you could just send messages to me as the host, but I don't think I achieved that. So just drop your questions in the chat. We will gather them all and we will answer them at the end. And yeah, that's the agenda for today. Some really quick housekeeping for all of you. I just wanted to show Zoom controls. There's mute and unmute, start video. We ask that you stay muted throughout the webinar unless you have a direct question, and in which case raise your hand and we'll call on you. Chat is available there in the middle. You can go ahead and do reactions as well. And then there's also, if you click the three buttons where it says more, you can also set up captions if you need to have captions up as we are going. So those are all there for you. Another housekeeping thing, we just wanted to, we know in public health we use a ton of acronyms. A lot of you probably know most of these. There might be a few you don't know. So I wanted to pause here. If you would like to screenshot this for your reference, if you are on an Apple computer, then it's Command-Shift-4, and then you just select the area. If you're on Windows, it's just print screen, or you can just take a picture with your phone. So just pausing here. And if at any point there is an acronym that isn't on this list that comes up, just, ask in the chat and we'll try and make sure we cover that. I'm going to pause for a minute longer. Okay. Giving everyone a minute to take a photo if they want, and we'll move on. So we would love to just do a really quick check-in. I would love to know, let's see, I'm just going to drop this in the chat to everyone. We have a Menti set up here. You can click that link, or you can go ahead and participate on your phone if you want to take a photo of that QR code. And what we would love to know is just, where are you based? Where are you working today? Just kind of get a feel for the people that we have here in the room. I'm going to pop on over so we can see people's responses. Already have answers coming in. Looks like we got folks from Tillamook, Yamhill Polk, not sure which one, but somewhere in that area. It looks like we got Marion folks, Clackamas, Multnomah, Columbia, we got Wasco, Sherman, Gillum, Umatilla, Baker, Malheur, Jefferson, Deschutes, Jackson. Of course, we got Lynn here today, Benton. I'm realizing I said Gillum, that might be Wheeler, because I did see, I saw Shelby. I don't think I saw Daleen or Holly. Give it just a beat more.
Laura, I don't know how to add mine. I'm on Mentimeter.
And you should just be able to click on it and it should drop a pin for you.
All right. Well, Klamath is here just in case.
Okay. Noted. Thank you. Sorry, it's not working for you. Okay. Looks like we hit critical mass there. Oh, there's Klamath. We got it. Okay, thank you. It's just great to see the spread and see how many folks we have across the whole state. Appreciate that. Gonna go to the next slide. This is open-ended. Go ahead and put in whatever response you want. What do you hope to learn from today's webinar? All right, we've got answers rolling in. CHW billing, how to enhance my MCH programs and have them grow successfully. Sustainable funding for MCH programs. How to get Medicaid reimbursement for CHW services. A lot of great things here. I'm gonna give it just a minute more. How to support nurses to better share the patient load. Love that. Understand the vision of how community health workers would assist in the work of the maternal health work of public health. Yep. And creative ideas for home visiting using CHWs and getting them billed. Examples of successful programs around the state. Yes. How to make it more sustainable. Absolutely. I think we're going to cover a lot of this today. If there are things that we don't cover, I think we have resources and some other trainings that have happened recently that we can point you to if something wasn't covered today here. Okay. Thank you all so much for participating in this. Appreciate it. I'm going to stop share for a moment. Oh, wow. So many people. That makes me so happy. I couldn't see anyone. So I had no idea how many people had joined. So just really quick, some context for today. We have, that last slide obviously showed that people have a lot of questions about MCH and billing for community health workers and how to incorporate community health workers into MCH programs. And that was really the reason for this webinar, the reason that this all came about. And we had heard from our partners in Linn County that they had had a ton of success with being able to build this out. So we've been trying to get this webinar together for, I think, a year now. And when we finally, all the stars aligned, and we are very happy today to welcome Shane and Monica, both with Linn County. And I will go ahead and pull up the slides and then turn it on over to the two of you.
Thank you very much, Laura. And our star here is Monica, just to be clear. That's not, I don't carry that title. I'm called a lot of things here, but that's not one of them. So we're here to talk about the MCH program. One of these things that I always do put out there as a caveat is, and I'm always open to the argument, but I always put forward that MCH is probably the most important program health departments run, period. It has long-term impacts on everything from child abuse in your community to increasing employment for both mother and child to 61% fewer arrests is one of my favorite ones for mother and 59% reduction in child arrests at age 15. But all of these are, high school education, completion. There are so many different data points that MCH hits that are none of our other programs really do. The unique part of this, though, is it is without a lot of political proponents because none of this work can be done during the term of a normal elected. This is the long game, really. if we run a solid, strong program for 15 to 20 years, we will get the rewards of this program. And it's just not going to turn around that quickly, though. So that's why finding ways to continually invest in these programs and keep them alive through good times and bad is going to be the key to success. So I'll get off my soapbox there and hop to one other thing that I just wanted to mention too. I did meet Dr. Hathi, the new OHA director, on Monday. And the first thing out of my mouth was, one of the low-hanging fruits that you can help us with and would get you a win right away is if you figure out a way to pay the match for all MCH programs, not just NFP and Family Connects. Because again, that's another space where I think a lot of us are probably, there's birth calculations you can do to figure out how many nurses you need. We did that here in Linn County. We determined that we technically need 7 nurses to meet our client load, but we, like all other counties, will never be at that because we can't afford that. It is best for us running it as a TCM business to run a little shy of that. We're running at 5 now. If we include Monica, the supervisor, but we're running at that point because then we always have a waiting list that we can leverage and make sure that our appointments are full. And we have such a narrow wiggle room financially. If they stopped taking that 1/3 or that match from, or the Medicaid match from us and just let us keep what we build for time, then that would open it up for us to actually provide services to all people. We still have the problem of, babies or mamas getting more and more pregnant than babies being born while sitting on a waiting list. And I think right now that's the business reality. So we need to do better. And Dr. Hathi was very aware of nurse home visiting. She was not aware of the Medicaid match problem. So this is my shameless plug to say, if she goes on a road tour in your part of the state, I think that if she hears that multiple times, that may be a powerful message that she can take home, and it wouldn't be a killer to any sort of state budget. So, okay, I will get off my soapbox now, Laura, I promise. So, MCH in Linn County, it has been a trip. When you hear from Monica, you will be talking to probably the person who was able to grow an MCH program more than anyone else in the state. So I want to give her time. I think it's important to also kind of frame where we were and where we are. We actually went from, at the close of our 2021 budget, or budget year, I think we had about 180 clients and somewhere around 200 encounters. And that's where we were at with, actually, we had just lost Rui, so we had 1 nurse and 1 community health worker. So it was really easy for me to promote Monica because she was my only nurse. But we have gone from that dismal past to our last closed fiscal year was 1,102 clients and 1,409 encounters. And again, those are billing. So we're talking about going from billing around 80 to 100,000 to billing almost $1 million a year. And that's how we built the program, and that's how we hope to continue to grow. But again, that Medicaid match would help a lot. Wink, wink. Okay. I'm shameless, aren't I? No. But I think that it's a real important kind of framework to say that, number one, this is possible even in a county that gets no tax levy for supports on these programs. I think that's why the Linn County may have been a little risk averse before, and that's understandable because a lot of times if you're not getting the visits and you end the year 20% in the red, then someone is knocking on your door and they're not happy, versus other counties that do have at least some tax levy going to kind of balance out some of these programs on different years. So we've definitely been taking a risk, but we are seeing those rewards. I mean, if you kind of tap the brakes and think about it, that's 1,102 people that the MCH program has touched, and that we will see likely down the road, even after only spending 3 or 4 months with them, some of the trial outcomes that I had already mentioned about graduation rates, about arrests, about subsequent pregnancies, child abuse and neglect, reduction in ER visits or accidents and poisonings. I mean, those are huge community values. And if we could ever measure those in dollars and cents, I think we would have 100% support of the legislature, hands down, because this really is truly a future investment. So with that said, I'm going to hand the baton over to Monica so she can talk specifically about how we've leveraged community health workers to pick up some of the burden and make things a little more efficient.
Thank you, Shane. Yes, if we want to go to the next slide, I'll just speak a little bit about why it's important to expand with support with our community health workers. And I want to talk a little bit more of like the why before we get into kind of like the nitty gritty of all the TCM stuff. We recognize that just by nurse home visiting that we're reversing the power differential in the home setting compared to like the patient nurse relationship in a hospital. And that's even more profound with a community health worker because they're able to be more of like a peer to match their community members that they're serving, and also match them culturally, linguistically, and also it enhances the trust a little bit if people have mistrust of the healthcare system by having that other person to kind of check in with, aside from the nurse. Let's see. So community health workers oftentimes come with some more lived experience that could be of more variety that can help in making that match happen so they feel safe, which leads to improved attrition rates. So you can go to the next slide. And with improved attrition rates, they're going to have improved health outcomes because if we work with them a little bit longer, we're able to meet the needs of their social determinants of health a little bit easier. Sorry, I'm going to my slide here for my notes. And with that, they can help expand access with co-case management with the nurse. So the nurse is pretty busy, as we know, and it's really hard to meet the needs of all of our clients when we only have a limited amount of time. So by expanding the service with the community health worker, we're able to meet like the access to service needs a little bit more efficiently, and clients are feeling like they have more attention to them. They're able to get their needs met a little bit better, and with that, they're able to meet their discharge goals. In nursing, we're always trying to kind of think ahead about the discharge process because discharge is success. You know, you really want people to be sustainable in their own environments without the support of the nurse or the community health worker. So they're able to do a lot of the work with the families by teaching them how to access these services and care independently. We want to foster a lot of independence. We don't want to create them to be dependent on us to kind of get them connected to all these services. So just kind of thinking about that as we talk through this today as one of the visions that we have here that's been working really, really well for our families. And of course, with all of this work together, we can increase and expand billable TCM activities. I would like to just highlight in brief that TCM activities are oftentimes like connections to services. So it's going to be a referral to something in the community or health care, and we can also bill for monitoring. So you may like exhaust your referrals with a family, but you may be working with them on their health goals, and trying to meet those health goals over time is like monitoring, checking in, coaching, and support. And that is also billable. Things like screening, things like nurse assessments, those things aren't billable. Taking vital signs aren't billable, but anything with connections to services for targeted case management is. Next slide. So with that, I just kind of want to give a little bit of a process around what it might look like with the nurse and community health worker relationship with the co-case management. And billable services, I just want to kind of remind that like the CHW is going to expand and improve the reach to the community that you're trying to meet. It's not a replacement of nursing. It's going to enable the nurse to really take on a larger caseload while the community health worker is able to check in with the families on things that are not necessarily nursing related. I mean, everything's nursing. We know everything's nursing, but it's helpful just to kind of think that way. It's been brought to my attention that some sites are curious if they could just do babies first and cocoon with a community health worker, and that's not possible. You have to have that co-case management relationship with the nurse, because TCM activities can only be billed through the assignments of the nurse care plan. Your nurse care plan can look like a lot of different things, but typically what it looks like for us is in TCM, we have certain assessments, plans, and goals that we have to meet. But within that space, we also have like our nursing SOAP note. And at the end of that, the P stands for plan. So we're able to kind of generate a plan with the client and the family, assign some tasks related to that plan to the community health worker, who then can follow up with anything that they need based on what the nurse is creating with the family. The TCM service also has to be co-signed by the nurse. So the community health worker can do the work, she can document the work, but the nurse essentially has to sign off on the work before it can be billed for TCM. So for us, we use like an EMR. So it just looks like a routed note that the nurse checks off. Other people, it may look like paper charting or something like that. You're just kind of signing, attesting that the information is accurate and ready for billing. By doing this, I mean, it does increase billable activities just by allowing the nurse to kind of expand the rules within the manual where TCM is allowed with babies first and cocoon for community health workers. Notes the nurse has to at least meet with the family every 3 months. So the community health worker can meet with them in between. So you really can expand if you have clients that aren't necessarily high acuity. I would say if you have clients that are high acuity, your nurse is naturally going to be checking in more, but they're also going to have higher needs. So that community health worker can kind of alternate visits with the nurse and manage some of that caseload. The next slide is rather overwhelming, but I'll just highlight it. I was asked just to provide some examples of what TCM activities might look like for a community health worker. And this is across the board, nurse or community health worker. These are general TCM activities. They're common. I'm not going to go through everything, but think a little bit about like your Maslow's hierarchy of needs. You need some housing, some shelter, some food security, and access to care. But you can really look at it through a different lens with thinking about getting them connected to services. So that could look like a support or peer group in the community. It could look like somebody really wants to learn how to speak English as a second language, getting them connected to that service. It can look as much as like going up and picking up a food box for somebody who's food insecure. Our agency allows us to transport patients because we have a pretty robust fleet and a pretty robust mental health team that has that kind of written for us that we're able to transport clients. So if you're taking them to appointments, anything like that, a community health worker can assist in, and it's billable. So the next thing to think about is there's so much on this slide. Your referrals and your follow-up can't be duplicated. So you really have to be tracking your referrals to co-case manage well with the nurse. So in our electronic health record, we're able to do that in a certain dashboard, and there's closed loop. So just making sure your communications are clear, because if you had an audit and you had duplicate referrals, then you're not going to be reimbursed for that work because it was already done. That being said, there are some nuances. If the client, for example, needs dental and pregnancy, but they're not quite ready and that referral's lapsed essentially, postpartum, they're experiencing some more discomfort and they're curious about making that dental appointment, then you can resubmit that referral. It's a new referral. But if you're continuously working like on smoking cessation or something like that, and they're just not ready, and that's like something you're continuously monitoring, then it's not necessarily something you're going to put back in and rebill for. I can get confusing. I can get more confusing about all this stuff, but these are things we've learned. So having that closed loop on your referral process with the nurse and the community health worker is really important. Okay, next slide. We can talk a little bit more about what it sounds like everybody else is more interested in. And it's around more of like program sustainability, expanding the billing. We had a formula that we created based on FTE, but not our fringe. So we were trying to, or sorry, salary, not our fringe. We were trying to create a formula of sorts that how many visits does a nurse have to do to be sustainable, and then how many would the community health worker have to do to be sustainable? The magic number was like 55 or something like that. So we kind of split it up. The nurse typically bills around 33. The community health worker, we want them to do at least 20. But the community health worker really does have a lot of room if FTE is awarded to them to not have multiple hats in other programs or responsibilities administratively to do way more visits than that. Because if they're just doing connections to services every day, they could really do a lot of appointments with people. If they're like our community health workers and they have other responsibilities, they might be managing an Oregon Mother's Care program. They might be doing OHP assistance. They might be helping with the vaccine programs. So just thinking a little bit about what that might look like for you as you work with your community health workers, because then they, just like the nurse is very busy, start to feel really overwhelmed. And then we have to think about how that's going to impact the families they're working with. Let's see. I think that's all for this slide. Okay. So a lot of the programs that community health workers I see kind of working in is, of course, Babies First and Cocoon. They're the only ones in Oregon that they can bill TCM. There is a program manual that kind of describes their roles, responsibilities, and it does offer a little bit of guidance. The guidance is new and it's been in development kind of with within the last 2 years, I want to say. So there is some context. I did work with one of my nurses who's no longer here on a community health worker policy and protocol I could share, just gonna have more guidance around kind of like what their scope might look like when they're working within these programs with the nurse. But other programs they can work in administratively is nurse family partnership, like office support, family connects, program support. And then I've seen a lot of community health workers manage and run Oregon Mother's Care independently and parents as teachers. I know Linn County does a lot of work with parents as teachers, and they kind of have the same co-case management space, but their community health workers are also parents as teachers providers. So they can offer a lot more parenting, coaching, and support for the families. So what I really like about Babies First and Cocoon as it sits right now, and I've advocated for it to stay this way, is that community health workers are not required to be certified when they start these programs. I think with that, it really builds an avenue of access, reduces the barrier for people wanting to serve in a maternal child health setting. Without necessarily having to have a certificate or some sort of education beforehand. What's great is if they do come in without a certificate is that most community-based organizations do this, but we've done this too, is we then can send them for certification. And sometimes, you know, there's grants and opportunities for that to be free, and sometimes not. We go through OSU and we've gone through the OHSU one with Cocoon. And it's not too expensive. I want to say like anywhere from like $600 to $1,200 depending on the program. They do have to have continuing education and things like that once they are certified every couple of years. So creating some space for that for them too is important. When you think about like administrative tasks that they're doing in like NFP and Family Connect, you can think about like scheduling, recruitment, data entry, building charts, managing phone lines, and appointment desk recovery type things with like rescheduling and scheduling, ordering inventory, material supplies, scanning, printing, mail outs, you know, clerical stuff too. But also like being somebody that does like some data Q&A, not Q&A, quality assurance, patient follow-up calls. The reason why Nurse Family Partnership and Family Connects don't have community health workers in their program model is because it's evidence-based, and with those studies, they've only focused on nursing. Babies First and Cocoon are not evidence-based. They want to work towards that, but definitely keeping the community health worker role in alignment with that. Okay, I've been talking a lot, and I recognize there are some really good questions in the beginning here that are in alignment with what we're talking about. So maybe we could just kind of open it up to questions, thoughts, or ideas.
Yes, absolutely. We've had some great questions come in the chat, and I will pull those up and go through some of those. One quick question was just, how much is the hourly wage for your community health workers?
Mm-hmm. So we actually just posted, let me look.
We don't really define our wages in hourly here in Linn County. Everything is monthly. But I just did a quick calculation and put in the $23.50 to $24 an hour in that range. But I think that one of the important things that Monica emphasized is the interplay between the community health worker and the family and the nurse and the family. In some of these roles, especially for lower needs clients, you know, you can have the nurse come in, meet the family with the community health worker. They can write, or the nurse can write up the care plan, and then the community health worker may, again, billing at the same rate as the nurse, be the person who sees them the next 3, 4, 5 visits before they see the nurse again. So I think that that's one of the important pieces. When I'm looking at total compensation packages, because I did see some managers on this call, so I figured I'd pick on them directly. But you know, when we look at total compensation packages, and we're including fringe and payroll costs, longevity, and all of the other things that go into it, and we're not talking about salary, sometimes we can see drastic differences that impact our budget in terrifying ways. But you know, like when I look at when I compare one of our, I'm picking them random alphabetically, the first nurse on my list is coming up as a salary total with fringe, retirement, and everything, $159,000. And the first CHW I'm seeing is salary total $108,000. Oh, and another one, salary total, just because of a different sized benefits package, $92,000. But you can see, you know, and I'm just, I would love to talk pay equity at the same time, but just in the world of program maintenance, if I'm billing the same amount for someone that costs 2/3 the cost of the nurse, that is a huge budget win. It is what it is. And in some cases, that makes some of these budgets able to balance, whereas in other situations or scenarios, they can't. So I just kind of wanted to throw that out there in the pool of meaning or for discussion, just so we can kind of wrap our minds around that. The one other question that I saw in the chat, I'll let Monica answer the question about, have you had instances where you submit claims for billables and they're denied? The short answer is yes, but not because they're CHW's billing, because we are wrestling with one of the insurance companies because there are a lot of different reasons that could be. The second half of that question from Jennifer was, are your CHWs full-time or could one of them be a part-time WIC certifier? Our CHWs are full-time. We have 3 now. We're talking about posting for a part-time to supplement that work, but absolutely that WIC, or I mean, if you had a full-time person where half their time was in WIC and the other half was doing this type of work, that would definitely be fair play.
The denials that come through sometimes, it's going to be how your EMR is set up, but just recognize that however you're sending it out, the nurse is co-signing, so it's going out under like a service of the nurse, because the CHWs can't bill independently. I mean, nurses don't either. It goes out under facility, but just how it's kind of presented on the claim, the nurse definitely has to be identified on there.
Gotcha. Thank you both. And then let's see, we had a lot of great comments in the chat. There's one question about what does the handoff look like from the RN to the CHW, and do they, oh, it jumped. Do they both go to the first visit?
It's ideal that they go to the first visit because the first visit in both programs is just to develop rapport and obtain consent after we explain the program and they are interested in services, because then you're able to kind of present the care in a tandem visit like that it will be both of them coming together as a care team. The handoff looks like the nurse kind of creates her care plan and she'll create her assignments. We use a messaging system within OCHIN to create our assignments. So the community health worker will get that notification. She'll be able to track it and follow it on the correct patient. It doesn't go to their medical record. This is just like an outside chat within. And then she's able to close the loop with the nurse if she needs to. But really what happens is within the cosign, they're able to kind of identify that need was met. So the nurse will be able to, it is the nurse's responsibility to be like closing the loop on things and ensuring the work's being done, but the community health workers do a really good job at co-case managing and handing off that way. So whatever kind of filing system you want to use to create that space for yourself, just making sure that it is closed loop is important, because sometimes things can get lost to follow up and then that access to care for families is then delayed.
Gotcha. Thank you. And it looks like, Tillamook also put in the chat their kind of pathway for those having a nurse and a community health worker see these clients. And so I would just put out a request that if any of you have Linn County or any of the other counties on this call, if you have like a written process or any sort of policies to share, please send these to me so that I can share them with everyone here. I think there was a request in the chat to share any sort of policies that you have created around these programs. So just share the knowledge, share the love.
Yes.
So I can answer Jennifer's question about CHWs being funded by billing, but Monica, do you want to jump in real quick about because we're in the learning process with how to make TCM billing dance well with the MAC program or MAC time studies. The short kind of 20,000 foot view answer is generally speaking, if you have providers doing some activities that are MAC claimable, it's best to switch those MAC claimable activities off of that provider and onto another staff member, and then cut that provider loose, because then you have a much higher percentage on the backs of one or two of we have one CHW that's almost 100% MAC funded because she does all the recruitment calls and a lot of the work that falls within that area, and kind of loading it onto one person because the others are billing is the dance we've done, but we still have people doing both. We have people filling out a MAC survey and billing. But Monica, want to jump into the details on that? Or did I nail it? No.
I think you nailed it. I mean, I guess like my lens is like if they're doing direct services, we can't claim that. So I also recognize that MAC survey is random, so it's hard to kind of anticipate some of that work. But direct services, just like the nurse, they wouldn't be able to claim that as MAC time when they're working with the families.
I mean, one example may be we have one staff member that is a OHP certifier. So if that person is assigned to a client and they sign them up for OHP, all of that stays off the MAC survey. But we have other people or other nurses who refer to that CHW for an OHP sign up, which means that OHP CHW is not the provider. So we can claim that. So, and any other ideas about the dance, I'm interested in, because I want to make sure that we're using those funds the way they're intended. I know that we go through a lot of screening and some things through the MAC program that at times feel arbitrary, but the bottom line is those MAC funds are specifically to help health departments help low-income people. So when I approach it from that standpoint, I try to say anything that is not a direct service, we're putting on MAC, The question about CHWs are entirely funded by billing. They're not entirely funded by billing, but I get no tax levy. So we do have a kind of a dance between billing, between MAC surveys, and between a data sharing agreement that we have with our CCO that gives us a couple bucks too every year. And that's how I pay for actually the entire MCH team. So one thing that has been very powerful is just keep knocking on your CCO's door and reminding them that they will not meet two of their metrics if the local health departments don't have a strong MCH program. So that normally gets them talking.
There was actually a question that came in via email before the webinar, just asking about your experiences, engaging with your CCO, and if there have been any pressures from the state to move away from your current billing mechanism. Can you talk a little bit more about that?
We've had a unique experience with our CCO because we're all friends here, so I'll just kind of say, because like every 3 months when we call a certain position within the CCO, it's a different person, and we have to reintroduce them to the program and restart the discussion. And so we've had a lot of false starts that way, but we've largely been able to get help or participation from them in the form of dollars from just the simple metric of prenatal visits, which is one of the CCO's main metrics. And it was very apparent in the data before 2020, they were not meeting that metric. And then when Monica started building up this program, they all of a sudden moved from, I don't remember if it was 69% to 70%, and that pushed them over, and now they're around 71 or 72. But that was really one of the spaces that health departments thrive in. And remember, a good argument with the CCOs is simply that MCH programs are both important and will never be money makers. That's why hospitals haven't taken this from us a long time ago. That it is always we get to the end of the year and we're like, we broke even, and that's what we're always shooting for. But it's one of those spaces where it always has been, and it probably always will be for the foreseeable future, run by governmental agencies. So.
Absolutely. Thanks, Shane. And then there was a question. You mentioned 2 CCO metrics. One of those you said was prenatal visits. What was the other one?
Do you remember it, Monica?
Well,
Otherwise,
right
I'm
now,
pulling it
like
up in
right
the
now,
guidance.
right now we're kind of in contract negotiations, and what I'm seeing them highlight is like referrals to and connections to prenatal, postpartum, and behavioral or mental health. So we're kind of working on that piece with them right now.
I'll find the one on, yeah, I knew it had to do with referrals. One of them is titled prenatal care. And it's supposed to be, I think, within first 90 days. And the other one is related to referrals. So that's actually doubly why we've been capturing referrals in WIC as well, to be able to show them that, hey, a lot of this is happening, or organically inside health departments, and maybe we should be compensated for it, but
Oh, go ahead, Monica.
I was curious. Breeze put a comment in the chat about how she uses CHW with NFP. Is that for home visiting, Breeze, since you guys have parents as teachers?
So we use them similarly to Babies First and Cocoon, and we've talked to our nurse consultants about how this works, but because NFP is listed in the OARs as one of the billable programs. Can you hear me? Sorry, I realized my mic was up. That it's listed within that section that Oregon will approve community health worker support. So it might not be a part of the model specifically, but it's also not completely written off as far as the National Service Office for NFP is concerned. So, we'll assign tasks in a similar way, and then they're billing under the NFP program instead of Babies First or Cocoon. So we kind of just follow the guidance laid out by Babies First, and do it very similarly. And our parents as teachers, home visitors are actually, we've received some grant funding through ODHS, so we're removing those that team from working in combination with the home visiting nurses, and they're going to be their own standalone program now.
Nice.
So that's pretty exciting because we're reaffiliating with Parents as Teachers International and doing some pilot work under the Family First Prevention Services Act. And yeah, that contract went into place January 1st. So we will be referring out to that program as another service within our section here.
Nice.
Yeah.
That's great. I'm going to ask you more questions about the NFP stuff, because that's another
Yes.
opportunity.
Please
for
do.
us. Yeah. Thank you.
There is a question from Madison about, does the CCO reimburse you for services, or do they give you a lump sum for a category of services?
All TCM claims go out under DMAP, so it's like Medicaid larger, but the CCO reimbursement that we're working with is a completely different contract. It's a different relationship and different like initial engagement opportunity that we're doing with their members to get them connected to services or home visiting.
Gotcha.
And that would be entirely unnecessary if we had the Medicaid match, because I mean, the irony is we bill enough to run the program, but then we have to write a check to the state. And then we all of a sudden don't have enough money for the program. So then we scramble, So I think that's why, Laura, I'm back on the same soapbox, but I think that's why I think that this needs to be, a statewide conversation until we can get this done. And I did find it is the quality metric toolkit, timeliness of prenatal and postpartum care. And the window is 7 days, from 7 days to 84 days after delivery. And it is related to actually the exact care coordination that our MCH programs do with connecting people with specific types of appointments based on need, etc. So
I would also like to highlight, like, we are lucky enough to have a Spanish speaking nurse and a Spanish speaking community health worker. And the impact that that's had on providing direct services within their own language and having that community health worker kind of level of care has been really profound. And our clients have been given us really good feedback about how that's working for them. But I also wish that there was a better way to track outcomes, and I'm looking forward to Babies First working on some evidence-based kind of things as they develop their data collection process. But it's been really, really great to watch that growth. Just the trust and like relationship that it creates. And then it's been able to kind of get our faces back out there. You know, public health has had like a bad rap for a while. Getting that trust back out into the community has been nice.
Looks like we have another question in the chat. Do you have a program evaluation tool you've used to evaluate your MCH program?
Other than being harassed by triennial review recently? I mean, not a tool, no. Anybody else have one that we can all use?
Hi, this is Barbie over at Linn County. We're in the process of developing just kind of a general patient satisfaction or client satisfaction survey for,
Oh, okay.
for those clients that aren't kind of captured by the survey is required within certain programs.
Got it. Okay, so that kind of evaluation, like patient satisfaction. No, we haven't done that, but we also do that regularly with other programs. So that's definitely something to consider.
Rocky, go ahead. I see your hand.
Yeah, thanks. So I actually I'm looking for a tool, if anybody has one, to evaluate the program itself. I feel like we are in a place in Tillamook County where it's time to really reassess our program as a whole. There's been a lot of change over the last 4 years with COVID, all the way down to essentially shutting off all of our home visiting programs. At one time, we had to close everything, right? And we have slowly clawed our way back from that. And we have implemented a community health worker who is Spanish speaking. And just like for you guys, it made a huge impact on the clients that we serve. And our Spanish speaking clients have more than tripled. It is like the need is huge. And so we're, you know, there's good things happening, but I feel like we're at a place where we need to reassess kind of where we have been, the kind of the path we traveled the last few years and where we're at now, and then utilize that to make recommendations for moving forward. And I want to use that like kind of like an assessment to use that to kind of vocalize with our CCO and with other funding opportunities, whether it be grant or otherwise, to try to get some more money into the program. We also don't get any tax dollars. We're fully dependent on what we're able to bill, and then also we're attached to it. We're integrated with an FQHC, so the FQHC fills the gap. But you always kind of feel like the ugly stepchild a little bit sometimes, because you're using clinic generated revenue to close that gap, and the closer I can get to close. And then also that like if I can show like, hey, here's what we need, here's the demand, here's all the things, right? I need more community health workers. I need somebody else, another person who speaks Spanish. It'll strengthen the argument for putting more money into the program in terms of FTE. So yeah, I'm looking for a tool.
I know. I hear you.
On the point of FTE, actually, it was among some of our challenges here locally, it's simply getting additional people approved, even if we can afford them through our board. And we were surprised how, like, this was one subject area where they were very open and accepting to. I mean, they were, every time we said, hey, we want to go from 1 nurse to 2, now 2 to 3, now 3 to 4. I was surprised that went as easy as it did. Because in other areas, if I try to add people to the evil public health, it's a fight, so.
Yeah, for us, HR is a huge barrier because we're part of the county system, right? So we have to follow it, but yeah, I could spend lots of time talking about the challenges there. You know, we are definitely a round peg in a square hole, and yeah, it's a struggle.
We are coming up on time. And I did just want to mention one thing. Monica, in the presentation, you mentioned like the training programs that are available for CHWs and how you can bring on people before they're certified and then help them with that. I just wanted to flag and potentially give Madison and Janessa a minute to plug that we have the Healthy Rural Oregon grant here at CLO that will help pay for those training programs if you are in a rural area. But I'll pass it over to Madison to say more.
Hi, are you guys sick of me yet? I hope not, because I still have money to spend. So please reach out if you are one of those rural counties. You don't have to be completely rural as long as your department serves rural areas. We can help fund your CHW training or any trainings for those staff members that you have that do the direct community health outreach and services. So a lot of your maternal child health programs will qualify for that, especially, you know, if you're going out and you're working directly with community members. We can not only just do CHW training, but we can do skill-specific training as well. So if you have, say, nurses that want to be certified lactation counselors, we can help them identify a program, pay for that program. We've done programs on perinatal mental health or maternal child health in that way. It's really, really broad. I think we're also looking to put some folks through the Northwest Center for Public Health Practices Public Health Management Certificate Program coming up this cohort. So if you have folks that are interested in that, we could help fund that. So reach out directly to Janessa or I if you want to chat more just about like what we can fund, what kind of trainings are available, how we can help connect you, because it's a really great resource and we have money through summer of 2025. So we've got one more year to spend down. And yeah, so I'll throw my and Janessa's emails in the chat. Feel free to reach out to us there. And then I'm going to try to read through the chats that I just got. So
I will jump in here too. Janessa, nice to meet y'all. One of the things that we're really focusing on too is this like long-term sustainability of our grant. And that means like helping you all have instructors for some of these things within your own communities. So if you need like a mental health first aid instructor, right? We can help pay for that. If you want someone to be a trainer of something, please reach out to us. Because again, that's one of those places that we see that we can have a long-term impact on kind of building the capacity within the communities. So.
Big round of applause for Monica, Shane, Janessa, and Madison. Woo!
Yes. Thank you, everyone. If you have questions that we did not get to today, please email them to me. And I will follow up with everyone here to send out the recording, the slides, and I'll also send out Madison and Janessa's contact information. Thank you all for being here today. When you exit the Zoom call, there will be a link that pops up for just a very quick evaluation. It should take you less than 5 minutes to fill out. Please do that so that we can keep doing these webinars for you and keep improving them. So thank you so much, everyone, and have a wonderful day.